Thank you, ma'am. The very fact that I'm speaking here means that I probably just removed my surgical cap outside and come here. So today I'm going to speak to you more about medicine, and this understanding of drugs and hormones actually comes from mostly from pediatric surgeons. I think that pediatric surgeons started this entire domain of saying that diabetes is a treatable condition, at least puts it in long-term remission if you treated obesity. And in 1991, when a Jewish gentleman actually made this statement, who would have thought it, that surgery proves to be the best option for diabetes? Until that time, nobody had looked at GLP-1, GIP, or the various drugs that we are using or we are talking about today. So maybe today is the era of not saying surgery or medicine, but actually talking about a symbiotic relationship. Today I'm going to speak to you about a very exciting molecule. We've all seen and heard about this molecule. We've also seen the huge potential of this molecule in treating probably the scourge of this century, that's obesity. So when you look at two molecules and two hormones, actually, GIP and GLP-1, you would say, why mix the two when they've got contralateral actions? GLP-1 activity at the central nervous system, as we all know by now, even lay people know that it reduces food intake, increases satiety, and in turn increases nausea. At the pancreas level, which lay people would not know, but as doctors we all do know, that it increases insulin sensitivity and it reduces glucagon. Delayed gastric emptying is supposed to be a bugbear of GLP-1, but that's basically the way which this hormone actually works. What does GIP do? GIP also reduces food intake, but unlike GLP-1, which increases nausea, this actually goes on and decreases nausea. And therefore, when you see this drug, Tirzepatide, you see that the nausea is slightly less. What it does with the pancreas, whether it increases insulin secretion, increases glucagon like glucose-dependent way. But the most important effect of GIP is through the adipose tissue. It increases insulin sensitivity, it increases lipid buffering capacity, increases blood flow, increases storage capacity, and decreases the pro-inflammatory immune cell infiltration. And we all do know that obesity is a chronic inflammatory condition. So, as a single molecule designated to activate both GIP and GLP-1, it's basically the native GIP sequence, okay? What it does is GIP receptor is similar to the native GIP hormone. But in terms of the GLP-1, its action is lower as compared to the native GLP-1 hormone. And because the half-life is approximately 5 days, it almost works out as a single weekly dose. The other good thing is that it is recommended for patients, and there's no dose adjustments required even in patients with renal and hepatic impairment. And we do know that diabetic patients, and especially obese diabetics, have some form of MASH, which is fatty liver disease in its extreme form with obesity, as well as diabetic-related retinopathy, obesity-related nephropathy. So all these things, when you don't need dose adjustments, it works for the molecule. Well, and in terms of the studies, Tirzepatide has been tried in various SURPASS trials, as well as in various SURMOUNT trials. So let's talk about the SURPASS trials. For those who do not know the various studies, well, the SURPASS 1 was with placebo. The SURPASS 2 was vis-a-vis semaglutide. SURPASS 3 was vis-a-vis insulin degludec. And SURPASS 4 was insulin gargling. SURPASS 5 was versus a placebo. So just so that you'll know where the SURPASS trials were. Now, these are the SURMOUNT trials. SURMOUNT trials was basically, the SURMOUNT 1 was all about weight. When they started increasing the Tirzepatide dose from 5, 10, 15 milligrams and pitched it against a placebo. They had almost 2,500 patients in that arm and a 72-week study. SURMOUNT 2 was weight management with type 2 diabetes of 10 and 15 milligrams of Tirzepatide versus a placebo. SURMOUNT 3 was intensive lifestyle program to start with, and then you had Tirzepatide versus placebo. SURMOUNT 4 was weight reduction maintenance, when you had Tirzepatide, which continued in one group, and after 36 weeks, it stopped, and you went on to placebo in the other group. And SURMOUNT 5 was Tirzepatide versus semaglutide. And in this, what they did is they took almost dose comparables, 10 and 15 milligrams of Tirzepatide vis-a-vis 1.7 and 2.4 milligrams of semaglutide. So almost equal labeling out over there. Now, the approved indications, as all of us do know, is type 2 diabetes and in chronic weight management. So both of these are approved therapies for the use of this drug. Now, let me just talk to you a little bit about these various trials. So when we talk about SURMOUNT 1, and if we can compare the various things, Tirzepatide gave you 16% total body weight loss. Remember that anything above 5% total body weight loss is and was an approved drug by FDA. Tirzepatide 10 milligrams was 21.4%. When we switched over to Tirzepatide 15 milligrams, you saw that the jump was not too much, not that you got an additional 5 or 6% total body weight loss, whereas placebo was just 2.4% total body weight loss over a 72-week period. So the average reduction in body weight with 5 milligrams was 16%, and with around 15 milligrams was 22.5%. Hitherto, no drug had ever gone above 20%. So this is the first molecule ever that went above 20%, almost coming close to surgery. And we are used to seeing early results of 25 to 30% with surgery. Long-term data says around 20 to 25% with things like sleeve gastrectomy, which you all would be aware of. Then we come to SURMOUNT 1 in terms of how many patients achieved it. So in more than 5% total body weight loss, if you see that in placebo arm, around 27.9% achieved it. But with 5 milligrams, 10 milligrams, and 15 milligrams, you had almost close to 90 to 95% of the people achieving more than 5% total body weight loss. What happened with 10% total body weight loss? Well, it was a 75% almost with 5 milligrams, 86% with 10 milligrams, and almost 90% with 15 milligrams. When we came to 15% total body weight loss, well, 5 milligrams, only half of them achieved it, but still with 10 milligrams and 15 milligrams, you had more than 1/3 achieving the same kind of results. And when it went to more than 20% body weight loss, even then, at 10 and 15 milligrams, if you look at it, more than half of those people, and at 15 milligrams, almost 1/3 of those people still achieved 20% total body weight loss. What happened with the cardiometabolic parameters? Well, systolic blood pressure dropped at an average of 7 to 8.2 milligrams of mercury. Diastolic blood pressure again dropped by 4.6 to 5.5 milligrams of mercury. The triglycerides averagely dropped between 24.3% to 31.4%. HDL cholesterol, which we do know would be a good rise, would be around 7 to 8.6% rose, and LDL eventually went down by 5.3 to 8.6. So dyslipidemia definitely did improve with this drug. When it came to adverse reactions in SURMOUNT 1 trial, the two most common ones, nausea and diarrhea. If you see that with the dose escalation, there was a mild increase, but it was not statistically really significant. So compared to the placebo, of course, these drugs did produce around 24% nausea, 24 to 30% of nausea, and diarrhea in around 18 to 20% of patients. Constipation, of course, was lesser with the increased dose because diarrhea was more. Dyspepsia was around the 10% mark. The eructations was under 5%. And the most important thing was discontinuation due to adverse reactions was 4.3% in the 5 milligrams, 7.1% in the 10 milligrams, and 6.2% in the 15 milligrams. Discontinuation due to gastrointestinal issues like diarrhea or constipation, 1.3%, 2.8%, and 2.9%. So averagely around 3% due to gastrointestinal issues, people discontinued this drug. Now, when it came to the average reduction in SURMOUNT 5, when you compared semaglutide versus Tirzepatide, what you overall saw is that tirzepatide of 10 milligrams and 15 milligrams was 21.6% average, whereas 1.7 milligrams and 2.4 milligrams of semaglutide was 15.4. So maybe a combination or dual agonist like GIP and a GLP-1 was probably doing far better in terms of at least around a 5% to 5.5 to 6% increase total body weight loss. When it came to waist circumference, again, around a 7.9 inches difference between the two groups, semaglutide or tirzepatide. The overall safety profile of tirzepatide versus in some 1.5 trials, what you did see, again, like what we had seen, around the same type of nausea. Ideally, we would have seen little better nausea profile with tirzepatide, but the data didn't really prove it. The diarrhea was around the same thing in terms of gastroesophageal reflux disease, and dyspepsia, however, semaglutide was more than tirzepatide. Now, when it came to type 2 diabetes, even the lowest maintenance dose of tirzepatide, 5 milligrams, demonstrated a superior HbA1c regulation of 2.1% with 5 milligrams, 2.4%, and 2.5% with 15 milligrams. Now, the only difference here is that at that point of time, semaglutide was approved as 1 milligram. So you've not used the higher doses of 1.7 and 2.4 milligrams. Maybe you might get equal results with HbA1c controls. But as far as this SURPASS-2 trial went, they compared 1 milligram of semaglutide vis-a-vis 5, 10, and 15 milligrams of tirzepatide. When it came again, HbA1c control, as you can see across the board, you saw that at 6.5% and less than 6.5, at 5.7%, tirzepatide stood head over heels in front of semaglutide 1 milligram. Then superior weight reduction that did not plateau over the study period of 40 weeks. With semaglutide, you had some degree of plateau, whereas with tirzepatide, with the higher doses, it did not plateau, and it kept getting better and better weight loss. At 15% was almost 12.4 compared to 6.2 of semaglutide. So overall, they said that tirzepatide 15 milligrams helped nearly 3 times as many patients achieve a composite endpoint as compared to semaglutide 1 milligram. In terms of HbA1c control, weight loss of more than 10% and no clinically significant severe hypoglycemia. As you can see, that the more the drug milligram, the dosage of the drug, the better the control of type 2 diabetes and HbA1c. When it came to the nausea, of coursingly, you would see that 15 milligrams kind of gave more nausea as compared to the 5 milligrams. And semaglutide almost at 1 milligrams was similar to the 5 milligrams dose. So similar nausea, diarrhea, and various other abdominal side effects. The hypoglycemia events, as you can see, with semaglutide 1 milligrams was less as compared to the 15 milligrams of tirzepatide, of coursingly more, but that was expected as the dose rose. But severe hypoglycemia was almost similar. So you had hypoglycemia more, but there was no severe incidences of hypoglycemia, even with the 10 and 15 milligrams of tirzepatide. So in summary, I would like to say that I think we've got a fantastic tool to treat obesity, especially the diabetic obese population. Tirzepatide significantly reduced body weight by an average of 16% at 5 milligrams and at 22.5% at 15 milligrams. Tirzepatide demonstrated superior weight reduction versus semaglutide at 15.4% of semaglutide to 21% with tirzepatide. Superior HbA1c reduction with all 3 doses as compared to 1 milligrams of semaglutide. And most of the common side effects were nausea and diarrhea, which were dose-related and could be easily stopped. Thank you so much.